Welcome back to the deep dive. Today, we are immersing ourselves in what is arguably one of the most fraught, scientifically contested, and frankly, emotionally brutal medical controversies of our time.
We're talking about the persistent, debilitating symptoms that can follow a standard treatment for Lyme disease.
Exactly. We're diving straight into that deep divide between what is clinically referred to as post-treatment Lyme Disease Syndrome, or PTLDS, and the term you hear more from patients and advocates, chronic Lyme disease, or CLD.
For years, the prevailing consensus from, the big medical organizations and the international treatment guidelines has been pretty rigid.
Incredibly rigid. The official line is that once a patient gets the standard short course of antibiotics for the Spirochete, Borrelia burgdorferi, the infection is considered cleared, done.
And any of those lingering symptoms, the crushing fatigue, the cognitive fog, that chronic widespread pain, they get classified as PTLDS.
Right, which is basically defined as a kind of post-infectious hangover, a ghost of the infection, and it's often managed with just symptomatic therapies.
And that leads to the core summary, the one you hear repeated endlessly in medical literature.
The mantra.
The mantra, yes, that repeated or prolonged antibiotics have shown no benefit in rigorous clinical trials for these patients.
But our sources today, and we have a comprehensive stack of them, from reappraisals of those very clinical trials to detailed biological studies, they suggest that the situation is far more nuanced.
Oh, much more, and frankly far less settled than those headlines would have you believe.
This is a story that's mixed with some really undeniable evidence of the organism surviving treatment, some surprisingly robust efficacy data that gets buried beneath safety concerns, and these profound ethical controversies that have just split the medical community right down the middle.
That's the critical tension we have to confront today. Our mission here is, well, it's multifaceted. We have to systematically reappraise the foundational U.S. clinical trials, the ones that underpin those conventional, very restrictive guidelines.
And we need to dissect the efficacy data that often gets lost beneath the final clinical recommendations.
That's a huge point. There's a big difference there. Furthermore, we've got to examine the biological forces at play, specifically the emerging scientific evidence that this organism can actually survive standard treatment.
How does it do that?
By adopting these antibiotic-tolerant forms. And finally, we're going to map out the political and ethical forces that have created this immense division. We'll chart the two opposing scientific hypotheses, and I think most importantly, we need to highlight the profound and often catastrophic human impact of this conflict on the patients who are just desperately seeking relief.
Okay, let's unpack this. Let's start with the core medical definitions. We've got two competing camps here, both trying to explain this reality of persistent, debilitating suffering. What's the clinical distinction we need to grasp right from the start?
Well, to really appreciate the current conflict, you need a little bit of historical context. Lyme disease isn't an ancient illness, not in terms of how we've recognized it.
Right, it's relatively new.
Very new.
Yeah.
It was only formally recognized in the U.S. in the 60s and 70s, following these highly publicized clusters of mysterious illness.
The one in Connecticut.
Exactly. The outbreak of severe arthritis reported near Old Lyme, Connecticut, starting in 1975. The actual bug, the causative agent, that corkscrew-shaped bacterium, Borrelia burgdorferi, that wasn't even identified until 1981 by Willy Burgdorfer.
Wow, so really recent history.
In medical terms, yes. And early U.S. studies immediately characterized it as a really serious systemic infection. If it was left undiagnosed or untreated, it could spread everywhere. We're talking joints, heart, the peripheral nervous system, even the central nervous system.
So everyone agreed from the start that the initial infection was serious business.
Absolutely. And that early severe characterization is important because it establishes the baseline seriousness of the infection itself. So the scientific divide, the whole conflict, it emerges at the precise point where a patient has received a standard course of antibiotics, say 14 to 28 days of doxycycline, and yet months or even years later, they are still suffering.
Still dealing with that profound, life-altering fatigue, pain, cognitive deficit.
Exactly. The entire conflict, therefore, centers on two mutually exclusive hypotheses for what's causing these lingering symptoms.
Okay, so let's start with the conventional side, the post-infectious sequelae hypothesis, or PTLDS. What's the argument there?
This hypothesis is generally aligned with the conventional medical view. It's championed by bodies like the Infectious Diseases Society of America, the IDSA.
Okay.
The core assertion is that the active infection, the live bacteria, is gone. The antibiotics did their job. It's over.
So the lingering symptoms, the deep fatigue, the pain, the neurological issues, where are they coming from then?
They believe it's not due to viable bacteria, but rather residual damage. It's the aftermath.
Like the collateral damage from a battle?
A perfect analogy. This damage could take the form of chronic inflammation, maybe from immune system dysregulation that was triggered by the fight. Or it could even be secondary autoimmunity, where the immune system gets confused by that past battle and starts attacking the body's own tissues. It's a sustained collateral damage flare-up long after the invading army has been vanquished.
Okay, and if that hypothesis is correct, that the symptoms are solely residual damage or chronic inflammation, then the treatment implication changes completely.
It has to.
You shouldn't be giving more antibiotics.
Absolutely not. The focus shifts away from antimicrobials and it moves toward fixing the damage.
Yeah.
So treatment centers on things like immunomodulation, anti-inflammatories, or purely symptomatic management.
Right, and we saw a really powerful example of this in our sources, the story of one patient, Ashley Baker.
Yes, she had a confirmed Lyme history, persistent symptoms, and was told by a specialist that the recommended course for her PTLDS symptoms was simply, and I'm quoting here, cognitive therapy, yoga, meditation. That is purely symptomatic management. It's trying to help the patient cope with the symptoms, which is a direct reflection of that PTLDS framework, assuming the bug is gone.
Okay, now let's flip to the opposing view. Microbial persistence. This is often championed under the patient and advocate term chronic Lyme disease, or CLD.
The CLD hypothesis, which is supported by organizations like the International Lyme and Associated Diseases Society, or ILADS, argues something completely different. It argues that the symptoms are caused by viable B. burgdorferi that have survived the initial treatment.
They didn't die.
They didn't die, they just went into hiding. This hypothesis suggests the bacteria may be hidden away in the body in these antibiotic-tolerant forms.
What does that mean, tolerant forms?
Well, perhaps as persisters, which are metabolically dormant, so they're sort of sleeping, or, and this is a huge area of research, encased in protective structures known as biofilms.
Ah.
So since the standard course of antibiotics only effectively kills rapidly dividing, free-swimming bacteria, these protected forms just survive and continue to cause low-level damage or trigger ongoing immune responses.
And the treatment implication here is obvious. If the bug is still alive, you have to kill it, which means more antibiotics.
Exactly. More antibiotics, prolonged antibiotics, or potentially novel drugs. But this is where even the CLD hypothesis hits a bit of a wall. The sources indicate that conventional prolonged antibiotics often show, well, limited sustained efficacy against these suspected persistent forms.
So they don't always work long-term.
They might improve symptoms temporarily, and we're going to see that in the trials, but the organism often seems to rebound when treatment stops. And that realization, it shifts the scientific imperative dramatically. If persistence is real, the focus has to be on developing novel anti-persister drugs.
Things that can break down those biofilms you mentioned or kill the dormant bacteria.
Precisely. Rather than just cycling through the same existing antibiotics over and over.
This brings us to the core issue, the thing that creates the entire deadlock. The fundamental diagnostic failure. We have two completely opposed hypotheses, both plausible for the same symptomatic patient. Why, in this day and age, can't we just run a definitive test and find out if the infection is still active?
It all comes down to diagnostic ambiguity, and it's driven by the nature of our traditional diagnostic tools, the IDSA and the Western blot.
These are the standard tests?
They are. And they are antibody-based tests. That means they measure the body's immune response to the bacteria, not the presence of the live bacteria itself.
Okay, explain that a little more.
Well, when you're first infected with Borrelia, your immune system springs into action, and it produces these armies of antibodies to fight the invader. Even after you've been successfully treated, cured, and the bacteria are entirely eliminated from your system, those antibodies don't just vanish overnight.
They hang around.
They hang around for months, sometimes years. They serve as a kind of biological memory of that past infection.
So if I walk into a clinic today, I'm feeling terrible, I'm exhausted, cognitively impaired, and my traditional Lyme test comes back positive for these lingering antibodies, what does that result actually tell my doctor?
It tells them definitively that you had Lyme disease at some point in the past.
But not now.
It tells them nothing about your current status. It cannot reliably distinguish between a cured historical infection, where the symptoms are truly post-infectious sequelae, and an active, persistent one, where the symptoms are caused by ongoing, hidden microbial persistence.
That's the crux of it. It's like finding deep tire tracks in the mud outside a cabin. You know a vehicle was there, and recently, but you can't tell if the car is still parked around the corner, hidden behind the trees, or if it drove away hours or even days ago.
That analogy is perfect. This systemic diagnostic failure is the primary scientific impediment fueling the entire disagreement. It just forces clinicians into a corner.
So they have to choose a side, basically.
They do. They have to rely heavily on either strict evidence-based consensus, that's the IDSA path, or on clinical experience and patient self-reporting, which is more the ILADS path. Without an objective biomarker, a definitive tool that confirms the presence of metabolically active Borrelia, this clinical impasse is just going to persist.
Okay, that sets the stage perfectly for our second part. Since the diagnostic tests can't resolve the controversy, the medical community has to rely on the gold standard,
Right.
randomized controlled trials, or RCTs.
Right.
Now, we mentioned earlier that the standard summary of these big, federally funded U.S. trials is that they showed no benefit to repeated antibiotics for PTLDS. But the core argument of our reappraisal sources is that this sweeping summary is incomplete and even misleading.
It's critically incomplete. I mean, when guidelines cite no benefit, they often conflate a trial showing a lack of sustained benefit or a lack of a favorable risk-benefit analysis with a trial showing a lack of efficacy.
And those are vastly different things.
They're completely different things. So we need to look really closely at the methodology and the specific results of these major U.S. trials.
Okay, before we jump into the two key trials that actually did show some efficacy, we have to address the elephant in the room, the Klempner trial from 2001, because that's the one that's so often cited as the definitive evidence against long-term antibiotics. What did that trial set out to do?
The Klempner trial was a major multi-center effort. It was designed to test the efficacy of prolonged 5E ceftriaxone followed by oral doxycycline in patients with persistent symptoms. They had 129 patients.
And the design was rigorous.
Oh, very. 30 days of 5E ceftriaxone or a placebo, followed by 60 days of oral doxycycline or a placebo. The outcome measures were broad. Quality of life scales, pain, fatigue, cognitive measures.
And the final conclusion, the one that made it into the headlines and the guidelines.
The final conclusion was that antibiotic retreatment did not improve health-related quality of life compared with placebo.
Okay, so why does the reappraisal argue that this conclusion should be taken with a bit of caution?
There are two main reasons. First, the primary endpoint was improvement in quality of life, which they measured with something called the SF-36 scale.
And quality of life is a very broad, very subjective measure.
It is. And some critics noted that if the primary outcome had been focused purely on a debilitating symptom like fatigue or pain, the results might have looked different. That said, the overall statistical analysis was robustly negative.
Okay, and the second reason?
The second, and I think this is crucial, is that the Klempner trial wasn't really designed to rigorously test the persistence hypothesis. It just tested whether aggressive, prolonged antibiotics improved quality of life in a general sense. It set a very high bar for a broad overall improvement.
So while Klempner became the go-to source for antibiotics don't work, it might have missed some more specific symptomatic benefits.
That's the argument, yes.
Okay, so let's move to the S.PLD study. This one was from 2003, and it focused on a much narrower but highly disabling symptom.
The STOP-PLD study, which stands for Study and Treatment of Post-Lyme Disease, was a landmark effort. It was specifically designed to address severe, persistent fatigue. And again, it was a randomized, double-masked, placebo-controlled trial.
What were the enrollment criteria? What made this group of patients unique?
Well, they enrolled 55 patients who had persistent, and this is key, severe fatigue. To even get into the study, patients had to score really high on the fatigue severity scale, the FSS-11.
So again, we're not talking about just being a little tired.
Not at all. We're talking functionally impaired. They also had to be at least 6 months past their initial antibiotic treatment, and their prior Lyme diagnosis had to be rigorously documented.
And the intervention.
It was 28 days of intravenous ceftriaxone, a very strong third-generation IV antibiotic or an IV placebo infusion, and that was followed by 5 months of monitoring with no treatment.
So what did the results show specifically for that severe fatigue score? This is the point that seems to be consistently minimized in the standard narrative.
This is the data point that demands our attention. The results showed that significantly more patients assigned to the ceftriaxone group showed improvement in their disabling fatigue compared to the placebo group.
How significant are we talking?
The responder rate, that's the percentage of patients who experienced a meaningful clinical improvement, was dramatically high for the drug group. In the ceftriaxone group, 64% of patients showed meaningful improvement on that FSS-11 score.
64%. And the placebo group.
Compare that to the placebo group, where only 18.5% showed that same level of improvement.
Wow.
The statistical confidence in this finding was extremely high. The p-value was less than 0.0001. I mean, that is not a marginal finding. That is a powerful, statistically robust difference.
That ratio, 64% versus 18.5% responding to the primary outcome measure they were enrolled for, that is staggering. It completely reframes how you have to interpret that standard conclusion of no benefit, doesn't it?
It absolutely does.
How did they quantify the magnitude of that improvement?
They use something called the effect size, which tells us about the clinical importance, how big the difference really is. And the effect size they calculated for the fatigue severity scale was 1.0.
And for context,
For context, an effect size of 0.8 is generally considered large. This beneficial impact ranged from moderate to large.
so it was a big deal for the people who responded?
A huge deal. The reappraisal paper notes that if you compare this 1.0 effect size to trials for many common FDA-approved antidepressants or chronic pain medications, where effect sizes are often pretty mild, maybe 0.2 to 0.5, the improvement seen in the STOP-ELD trial was considered a robust behavioral improvement and a valuable treatment.
Imagine if a common painkiller worked that reliably on your toughest, most debilitating migraine.
That is the magnitude of the clinical finding here.
Okay, so we have clear, robust efficacy on the one symptom that was causing these patients functional disability, yet the official clinical guidelines frequently summarize this trial as showing no benefit. This brings us directly to that crucial divide, the efficacy versus recommendation divide.
That is the critical disconnect. The authors of the STOP-ELD study, to their credit, were very transparent. They concluded that ceftriaxone did result in improvement in severe fatigue. They state that plainly. But they ultimately concluded that they could not recommend repeated antibiotic therapy as a standard treatment.
And that's the contradiction. If it worked, why on earth wouldn't you recommend it?
It came down entirely to the high risk associated with the IV delivery method versus the fact that the benefit wasn't sustained and it didn't help with other secondary measures.
The side effects.
The side effects were serious. 4 patients in the study had serious adverse events that required hospitalization. For instance, 1 patient in the active treatment group suffered a pulmonary embolus.
Which is potentially fatal.
Absolutely, a blood clot in the lung. Other serious events included fever, anemia, and GI bleeding. The serious adverse events were just deemed too frequent for the level of benefit found.
Especially since they were treating chronic symptoms, not an acute, life-threatening crisis.
Precisely. And while the fatigue improved, the researchers didn't see a sustained, significant difference in secondary measures like cognitive response time, which they were also tracking.
So the key summary for you, the listener, has to be this. The treatment was clearly effective in relieving the primary disabling symptom in a large number of patients. That indicates that something was biologically responsive to the drug.
Right.
However, the high risk that's inherent in that necessary 5E antibiotic delivery method meant it failed the standard risk-benefit analysis required for a conventional clinical recommendation.
That's it exactly. And the reappraisal authors state this explicitly. They say that guidelines dismissing these findings as showing no efficacy are doing a disservice to the evidence base. For a severely ill patient who has lost their job, their financial stability, their quality of life, knowing there is a treatment that is 64% effective on their worst symptom, even if it's risky, that enables a thoughtful discussion.
It allows for shared decision-making.
Yes. They might decide that the potential benefit, even if it's temporary, outweighs that risk. Standard guidelines effectively prevent that conversation from even happening.
Let's briefly touch on the second major trial, the Lyme encephalopathy trial from 2008. This one specifically focused on cognitive impairment in these patients.
Right, this trial was a bit smaller. It enrolled 37 patients who were suffering from subjective cognitive complaints, but these were also backed up by objectively confirmed memory deficits.
And the design.
Similar. 10 weeks of 5E ceftriaxone or a placebo, followed by 14 weeks off treatment.
So the stakes here were dealing directly with brain function. What were the cognitive results? Did it help?
Well, on the primary cognitive measure, those objective memory tests, they noted a marginal cognitive benefit at week 12. So just at the end of the antibiotic infusion period, the p-value was 0.053, which falls just outside the conventional threshold for statistical significance.
So a hint of something, but not a slam dunk.
A hint, exactly. But the critical finding, the one that really drove the final conclusion, was that this initial marginal improvement was completely locked by week 24.
So 3 months after the drug was stopped, it was gone.
It was gone. The effect was not sustained. It didn't last.
Did they find any lasting benefits at all?
They did on secondary outcomes. The researchers noted a sustained improvement out to week 24 for pain and for physical functioning, particularly among the patients whose symptoms were most severe at the beginning of the trial.
So while the cognitive benefit vanished, some people did retain improvements in their physical health.
That's right. But once again, the authors concluded that due to that marginal cognitive benefit and the inherent risks of IV therapy things, like thrombus formation at the PICC line site, staph infections, biliary stones from the drug itself, repeated 5E antibiotic therapy was just not recommended for sustained cognitive improvement. The lack of durability was the fatal flaw.
So if the risk calculations stopped the recommendations back in 2008, what does the latest data tell us? I'm looking at this 2022 network meta-analysis. Does it confirm those efficacy results against the backdrop of safety?
The 2022 network meta-analysis, or NMA, is crucial. It's a systematic review that compares the results of multiple RCTs all at the same time, in this case, 4 trials involving 485 subjects. And it uses sophisticated statistical methods to rank the efficacy of different treatments.
Doxycycline, ceftriaxone, placebo.
All of them. And we should pause here, because what is a network meta-analysis?
Good question.
Think of a regular meta-analysis as a study of studies. It pulls data from multiple high-quality trials to get a larger, more statistically powerful sample size. The network meta-analysis takes it a step further. It lets you compare treatments that have never been directly compared in a single trial. It creates a whole network of evidence to rank the interventions.
And they use something called a CCRA value.
Right. CCRA stands for surface under the cumulative ranking. It's just a statistical tool to rank which intervention is most likely to be the best for a given symptom.
So what was the finding? What did this comprehensive ranking say about fatigue?
It strongly reinforced the PTLDS finding from 2 decades prior. When they compared outcomes on the FSS fatigue measure, ceftriaxone had clearly superior results compared to both placebo and oral doxycycline.
And the final ranking?
In the final ranking, based on that SUCRA value, ceftriaxone ranked as the best intervention for improving fatigue symptoms. It scored an incredibly high SUCRA value of 97.7.
That is nearly unanimous statistical agreement that ceftriaxone is the most effective intervention for post-Lyme fatigue among all the antibiotics they tested.
It is. However, the NMA also provided balance by confirming the treatment's limitations in other areas. It found no statistically significant difference between the antibiotic groups and the placebo groups for scores measuring depression, mental health, or physical functioning.
So the drug is highly targeted. It hits that fatigue component really hard in some people, but it's not a universal panacea for the broader psychological or physical parts of the illness.
It's a great way to put it.
And what did the NMA confirm about the safety profile? That was the issue that stopped the initial recommendation.
The safety profile remains the central obstacle. The systematic review cataloged the adverse events meticulously. Doxycycline, the oral treatment, had the highest overall adverse event rate at 45%, but most were pretty mild.
Things like photosensitivity, nausea.
Exactly. Photosensitivity at about 18%, nausea at about 10%. But for the IV treatments, the risks were severe. 4-ceftriaxone carried a 3.57% risk of anaphylaxis.
A severe, potentially life-threatening allergic reaction?
Right. But here is the critical detail that often gets obscured. The placebo group, who also had an IV line, a PICC line, placed. They had an 11-point Phoenician 1% incidence of IV sepsis.
11% incidence of sepsis in the placebo group. That's shocking.
It is.
It highlights that the core danger isn't necessarily the drug's toxicity, but the inherent risk of just having that long-term central intravenous catheter placed in you.
That's the point. The PICC line, which is necessary for the long course of 5E ceftriaxone, introduces this massive risk of infection and thrombus formation, or clots. This is the technological failure point.
So we have a robustly effective treatment for a debilitating symptom.
Yes.
But the delivery method is too dangerous for widespread clinical recommendation. This paradox immediately strengthens the case for the chronic Lyme advocates, doesn't it?
It absolutely does. They argue that if the drug works so effectively on fatigue, then the bacteria must still be present, and the search must shift to finding safer, novel ways to kill it.
That is the perfect logical next step. The clinical trial data suggests the organism is alive and is responding to treatment, even if that response isn't sustained. So the strongest scientific argument for chronic Lyme disease microbial persistence hinges on finding direct evidence.
Yes, direct evidence that B. burgdorferi can survive those powerful antibiotic courses.
Right.
And the concept of persistence is really built on the organism's adaptability. Researchers have known for decades that the Borrelia spirochete can transform into these alternative morphological forms. Back in the 90s, they were studying what they called round bodies, cysts, and granules, which seemed potentially antibiotic resistant.
But the science has moved on from there.
It has. In the last decade, the evidence has strongly coalesced around biofilms as the primary mechanism for persistence, not just in Lyme, but in many chronic bacterial infections.
So what exactly is a biofilm, and why does it represent such an enormous defensive barrier against antibiotics?
A biofilm is, it's essentially a highly organized, protective bacterial city. It's an aggregation of microorganisms that attach to a surface, in this case your human tissue, and then they encase and protect themselves with this thick, sticky, self-produced barrier.
What's it made of?
It's called extracellular polymeric substance, or EPS. The EPS matrix is composed of complex materials like alginate, various proteins, and even their own DNA. This substance creates a highly protective physical shield.
And why does this make standard antibiotics, which we know were robustly effective against the free-swimming spirochete, suddenly useless?
The significance is immense. Biofilms are known to increase antibiotic resistance up to 1,000-fold.
1,000 times more resistant.
Yes, compared to the bacteria just floating freely in your bloodstream or tissues.
Yeah.
And this resistance isn't due to some genetic mutation. It's structural.
So how does it work?
There are three main mechanisms. First, the EPS matrix acts like a physical sponge, so it leads to incomplete penetration of the antibiotics into the core of the structure. They can't get in.
Okay.
Second, the microenvironment within the biofilm changes. It slows the bacteria's metabolism way down, meaning they become metabolically dormant. And since most antibiotics, like ceftriaxone, only kill rapidly dividing bacteria, these dormant forms are basically untouched.
And the third?
They're simply a protected population nestled deep inside. Biofilms are implicated in notoriously chronic conditions, things like osteomyelitis and cystic fibrosis, and many researchers now believe this mechanism is exactly what explains the survival of B. burgdorferi in chronic Lyme disease.
Now we can turn to the specific, detailed autopsy case study in our sources. This moves the persistence hypothesis from something theoretical to a tangible, anatomical reality inside a human who received massive, massive amounts of treatment.
This case is one of the most compelling pieces of evidence for microbial persistence in human tissue after aggressive treatment has failed. It involved a 39-year-old woman with a history of Lyme neuroborreliosis. She was suffering from symptoms like spastic paraparesis and cognitive impairment.
And to really understand the implications here, we have to stress the extent of her antibiotic exposure. This wasn't a standard 2-week course.
Her treatment history was staggering. She had 21 days of 5-E-cefotaxime, oral minocycline, pulse regimens of 5-E-cefotaxime over 10 months, 10 days of 5-E-ceftriaxone.
And it goes on.
And later, a continuous regimen of 5-E-cefotaxime for 109 consecutive days. She was essentially saturated with high-dose antibiotics for years, yet her symptoms persisted, and that led to her death in 2003.
Did they have proof the infection was still active before she died, while she was getting all this treatment?
They did. Her spinal fluid yielded B. burgdorferi growth after her initial treatments. More crucially, B. burgdorferi DNA was demonstrated by PCR in her blood on multiple occasions between 1995 and 2001.
So that confirms a systemic presence long after her aggressive antibiotic courses were supposedly complete.
It does. And the actual autopsy findings, which were conducted by researchers 16 or more years after the tissue was collected, were extraordinary in their scope and consistency. They examined 4 different critical organs: the brain, the heart, the kidney, and the liver.
Using multiple validation methods.
Yes. And what they found in those 4 organs was evidence of B. burgdorferi positive spirochetal clusters and these large, irregular, dense aggregates that looked exactly like biofilm structures.
And they found this in all 4 organs.
In all 4 organs. This wasn't a localized infection. This was evidence of systemic persistence.
How can the researchers be absolutely certain that these structures were actual biofilms and not just some kind of, cellular debris or artifact?
This required really specialized techniques. First, they used immunohistochemistry, or IHC, to stain for the bacteria itself, and that confirmed the clusters were Borrelia positive.
Okay, so they found the bacteria.
Right. Second, and this is the key to the biofilm confirmation, The aggregate stained positive for the specific biofilm matrix marker, alginate.
And alginate is a major component of that EPS, that protective shield.
Exactly. So finding it confirms the physical structure of a biofilm.
Hmm.
And finally, they used fluorescent in situ hybridization fish.
What's that?
Imagine using a glowing, tagged piece of genetic code, like a highly specific smart bomb that only locks onto the unique DNA sequence of Borrelia.
I see.
The fish-use technique confirmed that these aggregates contain B. burgdorferi-specific 16S ribosomal DNA, and they backed this up with PCR and whole genome sequencing of the liver tissue, which confirmed the presence of the B. burgdorferi DNA with 99–100% identity to the standard strain.
The conclusion seems inescapable.
It is. The organism, protected in a biofilm form, can survive massive doses of antibiotics and remain widely disseminated in the body.
Okay, so here's the point where we have to tie biological persistence directly back to the chronic symptoms. Persistence alone doesn't prove it's causing the problem. What did they find regarding inflammation? Was the immune system actively reacting to these hidden structures?
This is the crucial link. The researchers looked for signs of an active immune battle. They focused on aggregates of CD3 plus T lymphocytes. These are immune cells that indicate an active specific inflammatory response.
And did they find them?
They found them densely aggregated, surrounding the B. burgdorferi biofilms in the brain, kidney, and liver tissues.
So the body was fighting them.
This provides really strong support for the CLD hypothesis. The drug-tolerant biofilm is not just sitting inertly in the tissue as some historical artifact. It is actively provoking a chronic inflammatory response.
And this continuous, low-grade yet intense inflammation is the likely driver of the patient's debilitating chronic symptoms. The pain, the cognitive impairment.
That's the theory. The persistent bacteria, hidden by the biofilm, continuously irritate the immune system, leading to sustained illness.
So the scientific truth is just so much more complex than the simple PTLDS definition allows. We have evidence of robust efficacy for a key symptom in clinical trials, suggesting the bug is alive and responding, and we have definitive biological evidence of the bug surviving in human tissue, hidden inside these antibiotic-resistant biofilms.
It's no wonder the conflict is so intense when the scientific evidence is so contradictory and complex.
Right. The clinical data points toward treatment efficacy, but it's not sustainable. And the biological data points toward a mechanism of persistence, the biofilms, that perfectly explains why the treatments aren't curative.
And that stage is set for a major breakdown in medical consensus.
That breakdown is exactly what spills out into the social and political realm, creating these divergent guidelines and really extreme patient hardship. This is where the medical civil war truly rages, and it forces patients to choose between two fundamentally different approaches to their own care.
The clinical divergence is best encapsulated by the two leading medical society guidelines. On one hand, you have the IDSA guidelines, which are inherently conservative.
Very conservative.
They rely strictly on established clinical consensus and data from conventional RCTs, like Klempner and Fallon. They emphasize rigorous, measurable outcomes and safety above all else. So they recommend short courses of antibiotics and restrict coverage for anything beyond that.
Okay, and on the other hand?
On the other hand, you have the ILADS guidelines, the International Lyme and Associated Diseases Society. Their organizational values place a significantly higher priority on reducing morbidity and improving quality of life for patients with this persistent, debilitating disease.
So they're looking at it from the patient's perspective of suffering.
Very much so. They operate under the belief that the current evidence, including that persistence data and the efficacy data for fatigue, justifies endorsing antibiotic retreatment and therapeutic flexibility.
So they might use long-term antibiotics.
Yes, often using long-term antibiotics based heavily on clinical judgment.
Yeah.
And they make this explicit ethical argument that withholding a potentially effective treatment due to risk concerns may result in an even greater disease burden for a patient who is already severely impaired.
This split in formal guidelines gives rise to a really controversial figure in the medical landscape, the Lyme literate medical doctor, or LLMD. What characterizes these practitioners, and what kind of risk are they taking?
LLMDs are the practitioners who practice on that side of therapeutic flexibility. They're often treating the patients who have failed the standard IDSA care and are just desperately seeking other options. They operate on the cutting edge, often treating beyond IDSA recommendations.
Using long-term antibiotics, combination therapies, maybe herbal remedies.
All of the above. And a survey of 155 Lyme-literate medical providers highlighted the immediate professional risk they assume just by challenging the consensus. 39% reported being subjected to an inquiry by a medical board, an insurer, or a hospital quality improvement body.
Just for their non-standard practices.
Exactly. They are deliberately stepping outside established norms and facing professional scrutiny as a result.
And this is where the controversy becomes so politically charged. As the medical establishment and these advocacy groups clash publicly, we have to report impartially here on the organizational response to this patient pushback. Our sources include commentary from major institutions that view some elements of the advocacy movement with deep skepticism.
That's a crucial distinction to make. Our sources, including a paper from Johns Hopkins, note that some activists within the Lyme community portray the disease as insidious, ubiquitous, difficult to diagnose, and almost incurable.
And treatable only with long-term, unvalidated methods.
Right. And these institutions assert that this perspective has created a kind of parallel universe of pseudoscientific practitioners and publications, fueled by distrust. And that leads to coordinated public protests and even accusations of corruption against those holding conventional views.
And the source lists some very specific, very serious allegations.
It does. Allegations related to the actions of some LLMDs and advocacy groups, examples of professional and legal issues, including instances of alleged scientific misconduct and disciplinary actions by state medical boards.
I mean, some of these cases are extreme.
They are. Some involved actions like selling medical equipment for a non-existent epidemic. In the most extreme and tragic cases documented, there was imprisonment for fraud or even manslaughter, like in one terrible case of a patient treated with injections of bismuth. So this side of the conflict involves intense legal and ethical scrutiny aimed at those who deviate significantly from the clinical standard of care.
Given that polarized atmosphere, the central human tragedy here is the patient experience of invalidation, which has become widely known as medical gaslighting.
This is the ultimate fallout of that diagnostic failure we talked about at the beginning. Gaslighting is a manipulation technique, and it's designed to make someone doubt their own perception of reality.
And in this context,
When a patient presents with genuine, debilitating, chronic, subjective symptoms that can't be validated by the consensus tests, and the medical establishment insists the symptoms are psychosomatic or that the infection doesn't exist, it amounts to a crisis of legitimacy for that patient's suffering.
let's use the powerful anecdote of Ashley Baker to illustrate this. She had a confirmed history of Lyme, yet she was still suffering profound symptoms.
Right. Ashley Baker was diagnosed with post-treatment Lyme disease syndrome. She recalls her specialist meeting her and confirming the diagnosis. And she specifically asked if the Lyme was still in her blood, and the doctor confirmed, yeah, there's Lyme in my blood.
Okay, so the doctor admits the bacteria is there.
Right. But then when she asked the logical next question, so what is the treatment for the Lyme in my blood, the reply was the clinical recommendation for PTLDS.
Yoga and meditation.
Typically, it's cognitive therapy, yoga, meditation. She described the emotional impact as feeling completely defeated and dehumanized. Being told that the treatment for a bacterial infection he had just confirmed was in her body was purely psychological coping mechanisms.
That is the definition of medical gaslighting. Having your biological reality simultaneously confirmed and then dismissed as irrelevant to your treatment.
Absolutely. And this distrust leads to immense financial costs, as patients are forced outside the conventional medical system. And that brings us to the structural enforcement of these conflicting guidelines, the insurance denial loop.
This is the economic fallout that really pushes patients to the brink.
It does. Insurance carriers operate under those strict IDSA guidelines. They use them to deny coverage for any non-standard long-term antibiotic treatment, classifying it as medically unwarranted or experimental.
Which immediately pushes patients into staggering, expensive, out-of-pocket costs.
And prolonged appeal processes that are physically taxing for individuals already dealing with severe fatigue and cognitive impairment.
But patient advocacy has had some major political success in pushing back against this structural denial. We're seeing state-level legislative overrides.
That is correct. Advocacy has been extremely effective in the political arena. In response to sustained lobbying, some states have passed laws that mandate insurance coverage for long-term antibiotic therapy when a licensed physician deems it medically necessary.
States like Illinois and Massachusetts?
For instance, yes. They have effectively overridden the established national scientific consensus on clinical standards through political means.
And this political pushback ties directly back to that ILADS philosophy we mentioned earlier, the necessity of shared decision-making.
It does. The ILADS guidelines, which use the internationally recognized grade system, they emphasize that clinicians must engage in open, transparent dialogue with their patients. They recognize the ethical duty to consider the patient's individual circumstances.
So for patients with severe life-altering symptoms.
Exactly. Those who have lost jobs, livelihoods, years of quality life. They may rationally be willing to accept greater risks, like those associated with IV antibiotics and PICC lines, for the potential of clinical benefit.
Even if that benefit is not sustained or widely recommended for the general public?
Yes, this shared decision-making is a direct challenge to the conventional, more paternalistic medical model.
We've covered an incredibly complex terrain today. We've moved from the molecular biology of the persistent spirochete in human tissue all the way through the rigorous reappraisal of clinical trials that showed powerful efficacy, and finally into the bitter, profound human and political consequences of this conflict.
And the landscape is clear. The conflict is sustained by this profound vacuum of objective diagnostic capability. We have evidence of efficacy for a key symptom, ceftriaxone, for fatigue, and robust biological evidence of persistence, those biofilms in the DNA and autopsy tissues. But the standard treatments carry high risks, and they don't guarantee a sustained cure.
So what does this all mean for the future of treatment? How do we break this diagnostic and therapeutic impasse so that patients stop being caught in the middle of this war?
The consensus among researchers who are trying to mediate this conflict is that the immediate priority has to be shifting the focus. We need a mechanism-based resolution through rigorous research.
We have to move away from philosophical debate and get to objective facts.
That's it. We urgently need objective diagnostic tools, biomarkers, that can definitively identify the underlying pathology in a symptomatic patient. We need a way to know today if your persistent symptoms are caused by infectious persistence, the CLD model, or they're caused by chronic inflammation and immune dysfunction, the PTLDS model.
Are there any promising leads in that area? Are we moving closer to a reliable, objective test?
Yes, there are several lines of research. For instance, studies have identified specific subset mRNA biomarkers that appear capable of distinguishing healthy individuals from those with PTLDS based on their genetic activity profiles. Furthermore, a chemokine called CXCL13 has been explored as a potential neurological marker in spinal fluid, and certain inflammatory signatures, like CCL19, may help characterize and predict these persistent illness subtypes.
So the ultimate goal is actually profoundly simple and patient-centered.
It is. If objective biomarkers can reliably distinguish between these different patient subsets, then treatment can be appropriately tailored. Patients confirmed to have active persistent infection can be directed toward research on novel anti-persister drugs that specifically target and break down those protective biofilms.
And conversely, those with chronic inflammation but no active infection can be treated with targeted immunomodulation or specific anti-inflammatories.
Right. Until we have these objective mechanism-based tools, the conflict and the patient suffering will continue unabated.
That brings us back to the ethical question that was raised by those clinical trials. If knowledge is only valuable when it's understood and applied, and given the demonstrated measurable efficacy of aggressive 5E treatment in reducing disabling fatigue, as robustly confirmed by the Stambolelli study and the network meta-analysis, even if that treatment is currently too dangerous to recommend due to the serious adverse events caused by the PICC line.
It's a huge question.
What responsibility does the medical community have to shift the research focus to developing safer delivery systems or novel, low-risk oral agents that specifically target the persistent biofilm-protected forms of the bacteria? The science shows the treatment works for a significant population. The delivery system is the failure point.
Right.
And knowing that for some patients, the risks of inaction, the loss of health, livelihood, and quality of life are catastrophic, that focus on therapeutic innovation seems to define the ethical frontier of this disease.
It really does.
And that is where we will leave our deep dive for today. Thank you for guiding us through this incredibly challenging and often painful terrain.
My pleasure. It's a